Yes, thank you for joining us for the Ask the MCAS Expert Live Part 7 with special focus on cardiology and related disorders related to MCAS and POTS, dysautonomia, and how they relate to mast cell activation syndrome in a special honor of Dysautonomia Awareness Month. So we're here again with Dr. Tania Dempsey. I am Kendra Nielsen-Miles. I'm the Executive Director and Founder of EDS Wellness, for those that don't know. And we're thrilled to be with Dr. Dempsey again for the 7th time for this Ask the MCAS Expert Part 7, like I said, again, with special focus on cardiology disorders and how they relate to mast cell issues. So for those that are not familiar, have never joined us before, and this is a little bit different today just because of the way that we had to get the technology. It's a little bit hairier, I guess, just because my video is through my computer and the sound is through my cell phone, but it seems to be working okay. As long as you can hear me, that's great, but most importantly, as long as you can hear and see Dr. Dempsey, that's what is most important. For those that are going to be asking questions, please make sure that you ask the questions either in the chat on Zoom or on the chat on Dr. Tania Dempsey's Facebook, on the feed on Dr. Tania Dempsey's Facebook page. And I did check and the live feed is working. My hair dryer for the 2nd time did not today.
That was already some aura around you.
There's always something, I'm telling you. So at least we got the audio and the video kind of working here. So otherwise that was not the case for my hair dryers the last couple of days. So please ask questions under the chat on Zoom and under the live feed on Dr. Tania Dempsey's page. Even if I share the feed elsewhere, please ask the questions there. And as always, please remember that this is not medical advice. This is a disclaimer that we are here for educational and informational purposes only. The shorter the questions, the better, just because it makes it easier for us to read and get through questions. And sometimes they are complex. And I do recognize that, and we both recognize that some of the times the longer questions are really important to try to get to. So we do try as best as we can to try to answer as many questions as possible. The least personal, the better, if that makes sense. So sometimes I try to take personal questions and make them a little bit more broad, or I take a generic question and make it a little bit more tailored to like whatever our focus is for the month. So just remember, this is informational, educational purposes only. This is not to take over as medical advice or anything against what your doctor has decided for you, or even that you shouldn't even go see a provider. So most importantly, just educational and informational purposes only. And with that, we will go to the first question. Thank you everybody for your patience. Woo. All right. Does MCAS cause increased endothelial growth factor and vasculitis? Goes back and forth.
What do you mean goes back and forth?
That was just the 3rd part of the question.
Okay.
Does MCAS cause and increase endothelial growth factor and vasculitis?
Right. So vascular endothelial growth factor, or VEGF or VEGF, is produced by mast cells. Actually, they're produced by a number of cells in the body, but mast cells are one of them. And so it's a mediator. It's one of the mediators. I do often measure VEGF in patients. And so sometimes it can be a sign of mast cell activation, even though it's not typically used as a diagnostic, for diagnostic criteria purposes, but it can be helpful. Yes, so if VEGF has been being produced by mast cells, that could lead to vascular proliferation, angiogenesis, which means that blood vessels, arteries are being created in places where they probably shouldn't be. So it's usually abnormal angiogenesis. And then obviously, yes, vasculitis or inflammation in the vasculature is for sure a possible side effect of MCAS.
So would you go ahead.
No, go ahead.
I was just gonna say, commenting on how that would obviously impact the cardiovascular system.
Right. Yeah. Well, it can impact it on many, many levels and many different places. So when we say vasculitis, we're talking mostly about inflammation in arteries. However, you can have inflammation in veins, you can have inflammation in capillaries, you can have inflammation closer to the heart. So it's kind of a general term. I want to bring up something. I don't usually like to mix our topics, but I think it's important. I can't talk about VEGF and vasculitis and not bring up something that I treat a lot of also, and that is Bartonella. And I don't want to belabor the point, but Bartonella is an interesting bacteria that lives in very similar niches in the body to mast cells. And in particular, Bartonella loves to invade the endothelial layers and the endothelial layers of the vasculature. And so it has also been linked with elevated VEGF levels and the development of vasculitis and the development of increased angiogenesis. And there is a classic Bartonella sign on the skin. It's called the Bartonella track. Some people think it is actually like a stretch mark. It's not really a stretch mark, but it can look like that. And that is probably from increased blood vessel growth in that area. So I just want to mention that because there's so much overlap between the two, and Bartonella can certainly cause mast cell activation and make it worse. So I just think it's worth a mention. And as we're talking about the cardiovascular system, Bartonella also plays a role, an unfortunate role.
Somebody along those lines asked, so how would you find that inflammation that you mentioned that's associated with this? How would you find the inflammation? How test for it?
For vasculitis or for inflammation of blood vessels? So there are a number of blood tests that can help identify this. Typically these are autoimmune markers that people are looking at, and there are various autoimmune markers. And so that actually can be tested by it could be a rheumatologist. And typically rheumatologists would be the people you would see first for vasculitis, but cardiologists can help with the workup as well. Even aside from the mast cell perspective, there's still a workup that needs to be done for that.
I'd like to go back a little bit further and I know we're talking about POTS and dysautonomia, and so many of us have them or have been diagnosed with either dysautonomia in general or POTS, which is a form of dysautonomia. How is that related to mast cell activation syndrome?
So, what I'm going to be talking about is there's some research to support what I'm saying. There's some literature on this, but more needs to be published. So a lot of what I'm telling you is anecdotal, is based on my experience with this. And so we understand that mast cells play a role in the nervous system and the vascular system, and as such they can affect function, right? So if we talk about mast cells in the nervous system, we did a Facebook Live on neurologic conditions and mast cell activation, and POTS actually can be both an issue or one or the other in the nervous system or the cardiovascular system, but probably both. And in the nervous system, the mast cells really just abut all the components of the nervous system, and when they release the mediators, they cause inflammation in the nerves. The nerves now are sending signals that are inappropriate, and that's where you get this autonomic dysfunction. You get the autonomic nervous system not functioning, not sending the signal to the vasculature to do what it has to do. So this is really where they overlap. And then in addition, you have mast cells that are in the endothelium of the blood vessel. So they're like sort of in the lining of the blood vessels. And then they're sending their own signals at, releasing mediators and sending signals at the level of the vasculature, which is affecting blood flow and regulation of oxygen transfer. Okay, so I believe that mast cells are involved in POTS, and I don't want to say all POTS is due to mast cell activation syndrome, but I think it's clear that many cases of POTS are associated with mast cell activation syndrome, and many could be even caused by mast cell activation. But there's certainly other causes of POTS, and we need to understand that there may be an autoimmune role, and that autoimmune role may be driven by mast cell activation syndrome. So it's complex. I don't think, again, I wish we had the full data on this, but there are more and more publications coming out from doctors who are interested in this, and so hopefully we'll get a better picture.
All right. I'm trying to also make sure that I'm looking at comments on Facebook too. So somebody was asking about, what about POTS causes ischemia and it's related to MCAS? What about POTS causes ischemia? Ischemia. And related to that. There I go. I sometimes butcher things, but you know.
That's okay. So the question is, how does POTS cause ischemia?
Ischemia, and is it related to MCAS?
Okay, so POTS on its own should not cause ischemia. Ischemia is a severe lack of blood flow to a certain area. So POTS alone does not cause that. But people with POTS who have mast cell activation syndrome, who might have other issues that affect circulation, could develop ischemia. So ischemia could happen, for instance, I'll give you an example. Let's say your intestines, which are getting blood flow from all the arteries, are not getting adequate blood flow. There's a blood clot, or there's a compression of the vessels and the blood's not going there. That part of the intestine could die. It can get ischemic. It's lack of oxygen. It cannot function. It's going to die. That can happen in the heart with a myocardial infarction, which is ischemia to part of the muscle in the heart. But POTS doesn't cause that. But mast cells could. But I think it's a separate issue.
All right, going back to VEGF, and we were just talking about that. What medications would be used to treat that?
So again, depending what the VEGF is caused by. So let's make an assumption that it's an MCAS-driven VEGF level. And let's say we haven't found any issue yet in the vasculature. There's no vasculitis. There's just an elevated VEGF. You want to obviously rule out other causes of elevated VEGF. And you say it's the mast cell, then as I've always said, then you target MCAS. You give, H1, H2 blockade. You try all the various mast cell stabilizers. And that alone could bring down VEGF levels because the mast cells are stabilized and not degranulating and releasing more chemicals. Now, if VEGF is caused by other things, VEGF can be produced by cancer cells, for instance. That's what makes cancer cells grow. They increase blood flow to the area where they are at. So that would be a different situation, and it's unlikely that someone would be diagnosed with cancer based on a VEGF. But I just want to make a point that there are other things that could cause elevated VEGF. And of course, if it's Bartonella that is determined to be the cause, then the Bartonella needs to be treated.
And going associated with this same question, can this happen in any veins?
Yeah.
Any veins.
Or arteries.
Arteries, yeah. Somebody asked about veins, but so it can happen in any veins.
Yes, yeah.
Okay, it can happen in any veins. And how would you find that in the nerves? I'm just reading a question that kind of was after that.
Maybe the question is regarding, I mentioned mast cells and their communication and their interaction with the nerves. There's actually no way clinically to find that. That's done in the lab. They know this information. That's actually been known for a long time. And that's why when we talked and when we did the neuro unit on Facebook Live, I think it was in July, I think. Yeah, a couple times ago. We talked about how mast cells, how controlling the mast cell can affect neurologic conditions, neuropsychiatric conditions, etc. So there's no way clinically to test for that.
Okay. One more question from Zoom before I go back to Facebook. Somebody said they've heard that Zoloft can help with POTS. Have you heard of anything about that? And if so, what is the mechanism of action that would allow it to do so?
Yeah, I think, all right, let me put it this way first. So there are some pretty typical drugs that are usually first line for POTS. In my opinion, it shouldn't just be those drugs. We should also be looking for MCAS, because I have POTS patients that actually don't respond well to POTS medications, but respond incredible to MCAS meds. And so I can controlling their POTS through the MCAS. But there are some patients who their POTS is very difficult to control. they've tried the POTS meds, maybe they've tried MCAS meds, and now they're going to the next line. And so Zoloft would probably be the next line. I have to be honest, I don't know the mechanism of action. We know that some of the antidepressants might have an effect on the nerves, maybe through these neurotransmitter interactions that it's doing at the brain, maybe it's doing at the level of the nerves that are feeding the heart and the blood vessels. But I worry about whether some doctors are using it because they're thinking that some of this is psychiatric. Okay, I don't mind the use of psychiatric drugs when they're needed. I just want to make sure that that's not how they're using it. And I think it's also important to understand that there are other things that sometimes need to be done. So if it is determined that the POTS is autoimmune driven, typically a lot of the POTS meds are not going to work. The MCAS meds might work a little, but maybe not. Then you might need IVIG, intravenous gamma globulins, to help stop that autoimmune attack on those nerves.
All right, here's another good question on Facebook. Somebody said, is there any documentation or articles about vascular hypersensitivity? People look at me like I'm crazy, and I just lost it. But basically any documentation on vascular hypersensitivity or articles.
Vascular hypersensitivity. I don't know if I understand that.
I'm trying to look at all the comments to read it fully.
So, I mean, it might be worth at this point, because I'm going to make some assumptions on that question, that we talk about something known as Conus syndrome.
Yes, that's been asked several times. So good. That's a good segue.
So let's do it.
All right, let's do it. There we go.
That's maybe what they're talking about when they say vascular sensitivity. What was the question?
Vascular hypersensitivity.
Oh, hypersensitivity.
Yeah.
Right.
But there's been a lot of questions on Conus syndrome.
Okay, so I think it's important to talk about. It's interesting because I want to give a little story here, and I don't usually talk about my family or personal stuff, but I think it's really interesting because when I really realized what Conus was, it just made so much sense, not only in a family member that I want to talk about, but also in others that I treat. So back in the day, there was a term called Prinzmental's angina. And it's still being used. It's really a spasm in the artery leading to the heart that can cause pain, that can cause decreased oxygen flow to the heart, could even lead to a heart attack. The difference between that type of angina and other angina is that the other type of angina, there's cholesterol buildup, and there's atherosclerosis, and there's a decreased amount of room for blood to flow, and then eventually there's like a clot that pops off the atherosclerosis, and then it blocks the blood vessel, and they get ischemia, they get angina, they get pain. So Prinzmental is basically saying, oh no, the artery is just spasming. It's a spasm. And back in the day when I was training, that's all we knew about this thing that could happen, that it spasms. We had no clue why it would spasm. We had no clue what to tell patients to do other than, take some nitroglycerin, which we would give to other patients who would have angina. So what's interesting was we now know that, it hasn't been proven, but I think many of us, and even many cardiologists that I work with, feel pretty confident that Prinzmental angina is probably Conus syndrome. And what I think is interesting is that my grandmother, when I was a resident at NYU, my grandmother, who passed away a couple years ago, she would have been next week, actually, she would have been 101. She passed away a few years ago, amazing woman. But for years, she had angina. She was probably 40 when she started complaining of angina. And the doctors were like, your heart's fine, take this med. And she would always have these weird episodes of chest pain. And I remember this one time, the chest pain was severe. We thought she had a heart attack. She didn't. They took her to the cath lab. They, looked inside, and she has no real blockages of any kind. She doesn't really have atherosclerosis. And they said, everything's fine. She had a spasm. And I remember them diagnosing her with Prinzmental angina. And so, years went by, and she would have these spasms. And then she was diagnosed around the age of 92 with celiac. and she went on a gluten-free diet. I believe now she probably had mast cell activation syndrome. I have plenty of things that I can go back over and say she had this for sure. But when she went gluten-free and we changed her lifestyle and all that stuff, guess what? There was no angina. There was nothing happening. She never had that again. She didn't have a heart attack. So I think it's so interesting now that I understand that she probably had, she may have eaten something, she may have had a stressor, she may have something that her mast cells in her arteries, which were particularly sensitive, for whatever reason, that was her weakness, would degranulate, release the chemical mediators, spasm, the oxygen wouldn't flow, she'd have chest pain, think she's having a heart attack, wind up in the hospital. So Conn's syndrome really is that there is a spasm in the artery that is driven by mast cell degranulation, which can be due to many, many things. So I had a patient a few months ago who had an episode of chest pain, which we believe is Conn's syndrome, and it was after she ate something. And I don't remember now what it was, but it was something that was not that unusual, not that crazy, but whatever was happening that day, she was under a lot of stress. There were other things are happening. Boom, she eats this thing. Next thing, she's in the ER. So I think Conn's is very important to understand because I think it's more common than we think. And I think much of what we've attributed to other types of cardiac issues really may be due to this. I hope that answered the question, but if people have additional questions about it, I'm happy to.
Yeah, I actually said the same thing. I said to, continue to ask more questions if they didn't get it more clarified. But it's funny, that was very similar to my grandmother. Grandma with the pills had a lot of angina. And now looking back, she definitely was hypermobile and she had a lot of mast cell problems. God bless her. She's the reason why I do a lot of things. So somebody asked about I wrote this down because the questions are going very fast on Facebook. Yeah. So myocarditis.
Okay.
And mast cell activation syndrome. Myocarditis,
pericarditis, myocarditis.
Yes.
Any of this inflammation that can happen around the heart, involving the heart muscle. Sure. It could be a virus. It could be a bacteria. Sometimes we don't know why it happens. But the end result is probably mast cell driven, and treating whatever the underlying cause is. So if it's an infection, it needs to be treated. And sometimes it's as clear as day. It's infection, you treat the infection, the myocarditis goes away. But it's not uncommon for patients to need steroids, to need anti-inflammatory agents. Why is that? And I would argue that that's because you're trying to manage the MCAS that's involving the heart and the area around the heart.
Okay. Another question is POTS and MCAS related cognitive impairment. Any thoughts on how to help that?
How to treat that? MCAS and POTS. So both of those conditions can cause significant cognitive impairment. Even in young people, I see, kids who, the joke is that they have a bad memory, but they're 10 years old. 10-year-old kids don't have bad memories. There's something going on. Or even adults, who worry that they're getting Alzheimer's or some kind of dementia. So we know that mast cells, I've said this before, right, are in the nervous system. And, if they're affecting nerve signaling and transmission in the brain, they're going to impair memory retrieval, memory storage. They're going to, they can affect the brain in many different ways. And some people, may have the memory component more. Some people are going to just feel like a brain fog, and they can still function, but they're functioning through this fog that is very, very disconcerting for them. So mast cells can do this. POTS can do this too, right? So POTS, not getting adequate blood flow to the brain often. So a lot of POTS patients will say, they function better, lying down than they do standing up. Lying down, they may cognitively feel better. Standing up, they feel worse. But they can also not feel good lying down. So how do you address that? Again, if there's an MCAS component to it, I'm going to treat the MCAS. And it may not be the first thing you try. So you might say, oh, I tried a lot of MCAS drugs, so it must not be MCAS because nothing really worked for that. Well, you just haven't found the key to your mast cell. So it could be something else you haven't tried. And on the POTS side, again, so I want to make sure that the MCAS is being treated on the POTS side. And I also want to treat the POTS. And I have seen a number of patients who have pretty severe POTS, some underlying MCAS, do really well with IVIG, which really just, calms that autoimmune response, and they get better cognitive abilities. Their cognitive function improves dramatically. But sometimes it's not that simple. Sometimes you do need drugs that are often used for like ADHD. They're stimulants. There are drugs that are used for people who have narcolepsy. Sometimes we use these things to sort of stimulate the brain and get it to wake up while we're dealing with the underlying issue.
All right. Another question. If you have a stent, can MCAS cause a stent to become blocked?
Yes. Yeah, and MCAS can cause the stent to move. It could cause the stent to get blocked or clotted. We know that foreign objects that are placed into the body in patients with MCAS, particularly if they also have EDS or some form of EDS, those foreign objects, they could be mesh, they could be implants, they could be, various things. They could be, hip replacements. Those things tend to move. They cause problems because the mast cells are probably impairing healing. They're probably sort of attacking that and sort of moving it away. So I've had patients that had, for instance, mesh placed for a hernia, and they know where the hernia was, and the mesh now is like on the other side of the abdomen. Because it moved. So stents are an issue too for some patients. Very, very important to manage that, to keep an eye on it.
Another heart problem, there's so many cardiology questions, and are they related to or how they related to MCAS? I think it's really important to talk about. Somebody brought up mitral valve prolapse. Could mitral valve prolapse be confused for Kunis or vice versa, especially within the people that have MCAS and EDS?
So,
theoretically.
So mitral valve prolapse alone is actually just it's a very common condition. Many people don't even know they have it. Sometimes it causes a murmur, sometimes it doesn't. It's just a little bit of a prolapse to that valve. And in some, when the valve moves, it causes a little like click or a snap. And so some people, you can hear it when we listen with a stethoscope, but not everybody has symptoms from mitral valve prolapse. So I want to make a point that years ago, doctors used to blame mitral valve prolapse or used to blame mitral valve prolapse when particularly women, because mitral valve prolapse does seem to be more common in women, they would blame the chest pain, the discomfort, the shortness of breath, whatever the symptom was, on mitral valve prolapse. I don't believe that it's really mitral valve prolapse that's really causing those symptoms in many patients. I think that was sort of a misnomer. I think it was just a way of them understanding. And I would argue that much of that, in terms of those symptoms, probably is MCAS. But again, how do you get doctors to think about it in a different paradigm, because it's completely different from what they're thinking of. But I don't believe it's mitral valve prolapse that's really causing the problems. I think it's probably MCAS.
All right. Another question that's related to, and I had one before that, but I'm going to read more on Facebook. Narcolepsy and sleep attacks related to MCAS. How are they? And I also know that's related to cardiology too. So narcolepsy and sleep attacks is what the question is, related to MCAS.
There is some relation to histamine for sure. And it's a little confusing, and we're really trying to work it out. It turns out that if you think about histamine is a sort of a stimulating type of chemical or neurotransmitter, actually. So, when you take an antihistamine, like Benadryl, it makes you sleepy. So blocking histamine causes sleep. Too much histamine causes people to be awake. And so with narcolepsy, there's some thought that there's too little histamine in part of the brain that is then causing them to fall asleep inappropriately, actually, is what they're doing, right? They're having tremendous fatigue. Some people are not having true narcolepsy where they're just sitting, talking, and then asleep. The fatigue for them, for some of them is incredible. So what they're using now is an H3 agonist/antagonist, which is actually increasing histamine levels in the brain to help keep them awake and give them energy. So it's a little bit confusing because a lot of people have been excited about H3 blockers coming out. This is kind of an H3 blocker, but then it kind of also stimulates histamine. So we're a little off topic. So I want to kind of go back and tie this into cardiology. And so we know that people with sleep disorders have more strain on their heart, more strain on their metabolism, more strain on a lot of different parts of the body. So sleep is so important. So regulating that sleep, making sure that the narcolepsy, the sleep apnea, whatever it is that is affecting you gets treated, because otherwise your heart suffers in the end.
Would you also like to talk about atrial fibrillation and how that can relate to MCAS? Ironically, my father has suffered AFib probably most of my whole life, and my husband now works for a medical device company for a wireless heart rate monitor, specifically to treat and diagnose AFib. So there's a lot of AFib in my family.
Interesting. So, I do a lot of genetic testing. So it's not uncommon for people. In fact, I have families that I take care of that also have a lot of AFib. And it's very interesting. You can often see in some of those patients who've done the genetic testing that they're carrying that predisposition for AFib. So in some of these patients, it really is just a predisposition and an altered, signaling pathway, and they get AFib. But I think in many, there probably is a mast cell component. And again, mast cells are there. They're in the vasculature. They're in the heart. They're in the nerves that feed the heart. I think that in some patients, AFib could probably be controlled if the MCAS is controlled, if it's determined that they actually have MCAS. And I have a number of patients whose AFib is controlled as long as everything else is controlled. I had one patient, by the way, who had a family history, but probably got AFib from babesiosis, and maybe as a secondary effect from it, and treating the babesia really helped. It didn't eliminate the problem, but it definitely helped, because babesia will drive mast cells as well.
Another heart-related issue, would long QT syndrome be affected by MCAS?
So my guess is yes. And I definitely have no way of proving.
Right.
But some people have long QT. They have this signal that when on an EKG, you see that there's a lengthening between the Q and the T. But some medications can bring it out. So you could actually have normal EKG. You take a medication. I'll give you an example. Azithromycin is one. It can cause a prolonged QT. And so why is it producing a prolonged QT? And I would say maybe it's causing a mast cell reaction, the level of the heart and the nerves, and that's why it's doing that. So again, I can't prove it, but I think it's interesting, and I think it's a possibility.
Well, obviously there's so much research that we have yet to really have done, and there's so much more that we need to do.
Yeah.
Somebody asked, does MCAS affect blood pressure? If so, how do you control it if the patient can't tolerate blood pressure meds? It's a good question.
Yeah, so, right. And so some blood pressure meds are hard to tolerate because there are excipients and fillers and all that in the drug, along with the drug. And so if you're an MCAS patient, you know that you're going to be more sensitive to excipients. And so the problem is that a lot of these drugs have a lot of issues. In fact, some of the blood pressure medicines that a lot of my patients are on, they're called ARBs, angiotensin receptor blockers. they were found to have that carcinogen that was also found in Zantac, and they pulled a bunch off the market. So then we had to scramble with a bunch of my patients for new drugs for them to try. And these patients can't just try new drugs, right? The reason they're on it is because we found something that's going to work. So it's really very, very upsetting and disconcerting for a lot of people. But let's just say, you've tried a lot of these drugs and you can't compound many of them, so you can't really get rid of the excipients. Then again, targeting on root causes may be acceptable depending on how high the blood pressure is. So if you're at like a 135 or 140 over 80, 85, and it's not dangerous, and you have some time, you're gonna work on diet, you're gonna work on lifestyle, you're gonna work on your mast cells. And so, I think it's clear that there probably is a link. I have children who come in who are actually, normal. They've actually seen cardiologists because of this reason, and they're told everything's normal. But when they come in, and especially if they're having a bad day, they're not feeling well, their blood pressure could be sky high. And I'm thinking, how can a 9-year-old have 200 over 100 blood pressure without any underlying issue? Well, she has mast cell activation. She ate something. She was upset about something. Boom, blood pressure is up. Right. And how do we control it? Well, she took an H1 blocker and then an H2 blocker, and then, she cleaned up her diet a little bit, and guess what? Blood pressure is normal now. So I think it could, I think there are solutions to it. I want to make a point. I pointed this out before, but, a lot of mast cell patients have metabolic issues. Those metabolic issues can cause clogging arteries and other heart issues, can also lead to high blood pressure and high cholesterol and all those things. And I think it's very important for many mast cell patients, particularly if you have risk factors for diabetes and heart disease and stroke, to really look at the diet, to really cut out a lot of the carbohydrates, because the blood pressure responds remarkably to getting rid of carbohydrates.
All right, this is another good question related to what you were just talking about. Can mast cells elevate heart rate, pulse accompanied by dehydration? So it's along the same lines of what you were just talking about. I think very pertinent a lot of times with teenagers and kids especially. So can mast cells cause elevated heart rate or pulse accompanied by dehydration? That's the question.
So the first part, can it cause elevated heart rate? Yes. That's no question. Can it cause dehydration? Maybe. Under the right circumstances, I can make a case for that. But dehydration will certainly make the heart rate worse, the MCAS worse. So whether MCAS is causing the dehydration is tough to say. Many of my mast cell patients who also have POTS do get dehydrated quite easily. They could be drinking 3 or 4 liters a day and still be dehydrated. Mm-hmm. And that has to do with third spacing. So it's like the fluid is going in and it's just like kind of going into like empty spaces in the body, or it's just being peed out. It's not actually going into the cells where it's really needed. So yeah, I could say, I don't usually call those patients dehydrated, but I will say that they have a fluid balance issue.
Yeah, for sure.
Sure. Yeah.
I think I asked that question appropriately. If I didn't, somebody can correct me. Okay, so going back on Zoom, there was no other questions there. I think we asked them. So going back, somebody asked about, does elevated, hold on, they're jumping really quickly. Hold on one second. Does elevated chromogranin level mean mastocytosis when all other blood work is okay? This is more of a general question. So if you...
Chromogranin A. So yeah. Chromogranin A is a mediator released from mast cells, but there are other things that can cause elevated chromogranin A. So number one, it depends on how elevated it is. I would never say that elevated chromogranin A means that you have mastocytosis. Mastocytosis is a cancer of the mast cell. And again, if that's diagnosed differently, you would have to have very elevated tryptate to really make the diagnosis. But a mildly elevated chromogranin A could indicate mast cell activation syndrome. It does indicate that release of mediator. But very high chromogranin A could indicate a neuroendocrine tumor, for instance.
Yeah. This was specifically, does it mean mastocytosis when all other blood work is okay? So I think you just answered that. Okay. Somebody asked about, what about tachycardia when I'm just starting to go to sleep?
I'm sorry, I was just looking at another question. Go ahead again.
What about tachycardia when you're just starting to go to sleep?
Very common, actually.
Yeah, it is.
Very common. Question. More common in women also, and I don't know why, but I suspect that some of it is positional. So, when you walk around during the day, you're not necessarily feeling your heart. You're not necessarily thinking about it. When you lie down, depending on the position, your heart, like let's say, for instance, you're laying either on your back or on your left side, your heart now is sort of lowered down. It's like touching the chest wall. And so you might be more aware of the beating of the heart. So I want to make a point that some of it is positional. And some of my mast cell patients are incredibly sensitive. They feel things in their body that other people would never feel. And so they feel the heart, whereas another person could have the same exact thing and lay in bed and not even feel it. So I want to make that point. But in addition, you have hormones that are released at night. You're not supposed to have much cortisol being released at that time because you're supposed to go to bed. Some MCAS patients have some adrenal dysfunction. Their cortisol levels are higher at night than they are during the day, which is why a lot of MCAS patients feel better at night and tend to do more work at night. And they tend to, they're night owls because their cortisol is a little higher. Cortisol is anti-inflammatory. It's a natural steroid. It's controlling MCAS. But when it's higher, it's also going to drive some of the heartbeat, heart rate, blood pressure, et cetera.
I think it's also important to point out that because so many of us are like what you just said, that if we continue to have other issues, like if we have hypothyroidism, that all of a sudden we're having consistent these heart rates. Sometimes it could also be an issue with something else that we have, like Hashimoto's not being managed.
Correct.
Yeah, and I only say that just because I have had exactly what you talk about, and I am that person. But I also have found that my thyroid went super hyper and was causing my heart rate to go crazy, specifically at night. So
yeah, and I'm so glad you mentioned that because in these live sessions, we're focusing on mast cells and we're focusing on all these disease states that are related. But you can have something happen to you in your body that's also not related to mast cell disease, and so you can say, I can make an argument that maybe Hashimoto's is somewhat related, though.
Right, I agree.
On some level, but you're right. What was happening was really not going to be controlled by controlling your MCAS. It's going to really has to be addressed by medication or whatever else has to be done. But also, just so you know, hypothyroidism, so underactive thyroid, theoretically should slow the heart down, and it does for some patients. But I have patients who get palpitations when their thyroid is underactive. So thyroid needs to be considered for sure. There are other things you definitely have to rule out cardiac issues if this is happening frequently, especially if there's an irregularity to it. So cardiologists might need to see you, an endocrinologist might need to see you. So yeah, you have to think, you can't always blame everything on, I'd love to blame everything on mast cells.
Right. Well, even if they are related, which a lot of times for me personally, I find that my thyroid issues definitely exacerbate mast cell issues, but that wasn't going to be at that time. It just kept going on and it was just, it was hyper. Okay. So somebody asked, going back to the salt fluid balance, what can you do? The salt fluid balance issue.
Yeah. So, okay. Eating more salt, taking salt pills, salt and potassium, taking electrolytes can help bring the fluid into the cells to make it sort of last longer. That's why when we give patients IV fluid, sodium chloride in a bag, it's basically, saline, salt water, that tends to make people feel better because it's sort of keeping the fluid in the blood vessels and in the cells and not kind of being peed out or in the extracellular space. So, so definitely looking at fluid intake and electrolyte intake is very, very important. There are other things that you might need to do. So there are medications, that can help regulate some of the fluid and electrolyte status. Something like fludrocortisone or Florinef can be helpful for some POTS patients who have this as an issue. It can help regulate that. And then, obviously there are a lot of other things that have to be taken into account.
Somebody asked along this line, what if you retain water and how do you increase fluid intake?
Yeah, this is, I just saw that question come up, and we have to address it because
it's a big issue.
It's a huge issue because so many of my MCAS patients have problems with edema and swelling. So, you want them to get more water in, and meanwhile, they're just blowing up. So
like a stuck pig, not naming names.
But for some patients, a very low dose diuretic that is given at the right time, along with fluids and electrolytes, can be helpful. It's a little bit of like chasing the problem though, but I have some patients where we figured out a way to help. In other patients, the edema and the swelling is MCAS driven. There's an inflammatory reaction. Some of these patients, it really has nothing to do with their fluid status, and yet it looks like they're having a problem. And it looks like it could be a cardiovascular problem if they have pitting edema in their legs. It could be a kidney problem, but it turns out that it's really MCAS. And so, it has to be addressed. You have to figure out if there's other root causes to it. Again, I hate to sound like a broken record, but Bartonella is something that I have seen cause significant edema and swelling in the legs, in the body, in the stomach. And so again, we got to get to the root cause.
All right, here's a couple of good cardiology questions. And I know we're at 8:10, and I know we started a little bit later. So I'm assuming, are you okay to keep going for just
let's do like another 10 minutes.
Okay.
Yeah.
Can you, this is a good one. Hold on one second. Okay, so if you have low BP, low blood pressure, but high heart rate, would you say that's more from autonomic dysfunction than MCAS usually? Theoretical question.
So again,
low blood pressure, high heart rate, is that more autonomic dysfunction versus MCAS?
Yeah, well,
probably hard to say.
Yeah, well, no. It's not, how do I put this? No one would say that the diagnosis of that is MCAS. Could MCAS be an underlying issue? Yeah, that's what we're saying. But it must be some autonomic dysfunction causing it. So I don't want to distinguish. They're not two separate things. They're probably related, MCAS and POTS, but you wouldn't call that symptom MCAS. You would say that there's some dysfunction causing blood pressure to go down, heart rate to go up. And in some cases, I see heart rate going up, blood pressure going up, right? And you're thinking, how can that be? And some people have this hyperadrenergic POTS. So you're actually getting increased levels of these catecholamines that are causing blood pressure to be high. But how can that be when the patients are feeling so crummy?
Well, that's a great segue into, can you explain a bit about hyperadrenergic? Yes, postural tachycardia syndrome, and it's in mast cell activation disorders.
Yeah. So let's see. How do I start it? I think did I lose you, or do you see me?
No, I can hear you. I can see you and hear
you.
Okay. I thought I lost you. No, I'm good.
So all right. So there are several forms of POTS. There's neurogenic, hyperadrenergic. Some people try to distinguish it, and there's probably like idiopathic, and we don't know. But the reality is that it almost doesn't matter which type it is. It does matter to some degree because you might use different medications. But the bottom line is that, again, it's my belief that much of this is driven by the immune system, whether it's mast cells, whether it's the autoimmune component, but something is driving this reaction. And so that has to be addressed, whether it's MCAS, again, treating the MCAS might help the hyperadrenergic POTS, might help some of these things, but it's not going to be a simple solution.
All right. Here's another really good question that I think both of us feel very passionate about. What happens if exercise triggers MCAS? How do we manage our heart health, specifically if it spikes the heart rate?
Yeah. Yeah. And it's so challenging because I love physical activity. I think it's so important. It makes me feel so good. I know you need physical activity, but there are definitely patients who are, so some can tolerate the heart rate to some extent. They're used to it. It's been happening for a long time, and they know how to manage what they can do. They may choose not to do a lot of cardio. They may do some weightlifting. They may do Pilates. They may do yoga. They've learned that there are activities that they can do that will not spike their heart rate. But I definitely have patients who cannot tolerate any exercise. And that to me means that we still have work to do. Like, we have to be able to find a solution so that the patient can have a better quality of life. And that is, being active and even just going out for a little walk. But if you have severe environmental triggers for your MCAS, let's say right now we have ragweed and mold in the air. And so you go out and you want to take a walk and you think you can walk, but then you're being bombarded by these environmental chemicals. It's really hard, because I have patients that complain about this all the time. It's sort of a catch-22. But I think a lot of it is about training, making sure that you're working with somebody. If you want to start to exercise, you have to have the doctor on board who is going to look at this and try to figure out how to control some of that symptomatology. And you have to have somebody maybe who has a background in exercise physiology or whatever. They can kind of help you sort of build stamina as well. I think a lot of patients can be more active than they think, but it does take time.
I think it's also interesting to point out that I just happened, because of my own interest in exercise, that histamine is used in movement, and it's released not just by the mast cells because it's like reacting to something, but it's released as a part and as a biochemical need for biomechanical needs in terms of movement that we still don't fully understand. But there are other needs for even just something like histamine. We think it's only released because of mast cells reacting to something, but it's used in movement that we fully don't understand.
I didn't know that.
Yeah, it's fascinating in my opinion. Have you seen any connections with Raynaud's and MCAS, POTS, and EDS? And I know that can be also related to cardiology, cardiovascular issues.
Or autoimmune,
right.
But it is a vascular problem. And Raynaud's, for people who don't know, usually causes people to have severe reactions to cold. Their fingertips can turn white, blue, purple. It can be very dangerous in some cases. That goes on too long if they're exposed to the cold. Certainly, my patients with Raynaud's find that this time of year, we're on the East Coast, and we are starting to see colder days and winter's coming, and so we're going to see people complain more of Raynaud's. So the question is, what's the connection? And there may be a connection. I won't say, not a lot of my MCAS patients say specifically they have Raynaud's. Many do, though. There are plenty that do, and plenty of those also have some other sign of autoimmunity. Whether the autoimmunity is being driven by the MCAS or the autoimmunity is being driven by something else, or it's just that they are an autoimmune person. So I won't say specifically related, but can be, certainly.
If you wouldn't mind going back to the water retention issues, because there seems to be a lot of questions related to that. I know a lot of us suffer, and that also affects our cardiovascular, our blood pressure, everything, and our ability to exercise. If somebody can't take diuretics, is there something else that can kind of work along the same way?
Yeah, so I don't think I have the specific ingredient or tool or medicine that I would say will work in every case. Along the diuretic line, there are herbs like dandelion that can have a natural diuretic effect. But that's not the point. The point is that a lot of this water retaining is not really water retaining. It's not how I traditionally thought of it when I was in training, in medical school training, and then even in private practice early on. I would see people with edema, and it would be, just which diuretic, how much diuretic are you going to do, and what's wrong with their heart, what's wrong with their kidneys, why is this happening? And what I'm saying is that many of my patients don't have a cardiac problem, they don't have a kidney problem. They are having an inflammatory reaction that appears to be like water retention. And so, some people will say, they have to lower their salt intake because it causes more retaining of water. I don't know. I don't necessarily think that that's the case, though. I have not found that to be helpful in my patients. What I have found to be most helpful is getting to the root and figuring out where that inflammation is really coming from. So I had a patient actually, I think it was last week, who, we've just found the MCAS protocol that was going to work, and the edema is significantly better, almost not happening at all. So again, for me, it's not about treating the symptom, it's about treating the underlying problem.
Right. It's fascinating. And it can be so frustrating. So thank you to talking about that, because I know so many of us, me personally, it's a daily battle. You feel like, what am I doing wrong? What's going on?
Can I ask a personal question?
Oh yeah, go ahead. I'm an open book.
I know you are. So I'm curious about the diversity in this problem. So are you getting pitting edema? Like if you take a finger and you put it in your leg, it's going in, or what is water retention like for you?
So the biggest issue that I personally have been dealing with that is very interesting, because a lot of the EDS doctors have never seen it, is that I am gathering water and then my legs, and specifically on top of my kneecaps. You could literally grab the fluid and the skin. And from what I understand, it's not pitting edema. Okay. I've done these, is this cellulite tests, but it looks like cellulite in areas that people don't necessarily get cellulite, especially if you're 125 pounds. To put myself on an open network, it's so severe that I don't even weigh myself, I weighed myself when I was on my menstrual cycle, I was 127. Like 5 or 6 days later, it said 134, and it was blinking abnormal. And then it said I was in the chubby category.
Oh my God.
But if you had looked,
so far from chubby. Okay.
But if you had looked and followed it, it was this distinct fluid retention that was significantly going up since April 2018. And it's specifically in my abdomen and my legs, and I don't believe it's pitting edema.
Okay.
And nobody understands why. It doesn't, I used to deal with it, would go ups and down, but
so now it's there. It's just there.
Yeah. I mean, high intensity exercise, sometimes fat, it's just always there.
I'm sorry.
Yeah, it's how.
Yeah.
That's why we're all here, right?
No, that's right. So again, so from my perspective, I would say it sounds like some people are writing in that maybe that they have similar problems.
Yeah. Can you squeeze the skin fat on your knees? That's what I want to know.
That's what I want to know too, because what I'm talking about is a little different, but what you're describing could certainly be in the same category.
Yeah, for sure.
It's collecting. I think the added issue is if you have EDS and you have connective tissue collagen issues, then the connective tissue is weaker, and the fluid can get into those spaces, and that's what you're talking about, it sounds like.
Yeah.
Like by your knee, maybe the collagen is weaker, and that's what the fluid is collecting.
Yeah.
The other thing I want to mention is that the issue with fluid is you have what's called intracellular fluid, and you have extracellular fluid.
Extracellular, right.
So intracellular means it's in the cell, it's in the blood vessels, it's everywhere it needs to be. Extracellular, you need some extracellular fluid, but not a lot, because that's in between the cells, and that's what causes fluid retention. Basically, when you see that the fluid coming out from the cell, it's where it's going, in your body, and that's what you're seeing as bloating or swelling. So the quality of the cell membrane and the quality, listen, the cell membrane is is like connective tissue, so to speak. Okay, there are components to it. There are certain types of fats that have to be incorporated into that cell membrane to help keep the water in, keep the organs in, organelles in the cell, and to allow garbage to leave the cell appropriately and things to come in appropriately. So in people who have this issue, there is a breakdown in their cell membranes. And I like to go down to the cellular level and say what's going on.
Yeah.
We use, there are a number of protocols that I use in my practice to help rebuild the cell membrane. Number one is getting enough fat in your diet. It's totally counterintuitive because you say, oh my God, the scale shows alert, and now I'm going to eat more fat. Like, what is that? What am I going to do to myself? I'm going to be 140 pounds.
Abnormal. When I've only been between 115 and like 122 my entire life. Never been 134 except pregnant. So, and I'm not pregnant.
Right. And this is something I think probably a lot of our viewers are relating to.
For sure.
This is a very common symptom that I see, this unexplained weight gain, unexplained fluid gain. It's so frustrating. But my point is that I have found success in managing the cell membrane. So getting enough of the right fats. Phosphatidylcholine is a main component. Phospholipids are a main component of cell membranes. So phosphatidylcholine as a supplement or as an IV, given in a couple different forms, can be helpful. And I think if you could rebuild that cell membrane and make the cells tighter, sort of like tight junctions, like everything is tight, then you have less fluid leaking.
Yeah, this seems like a lot of people are resonating with this. So I'm glad you asked me, and I'm happy to share this because I know that I can't be the only one that suffers this. And I think what happens a lot and why it can be so frustrating for somebody like who's a patient, and I can only imagine, is that, they look at the fact that, oh, Kendra, you work out all the time, you're so thin. But when you know yourself so well, 15 pounds in a year without really being that bad,
right?
In terms of like what?
It'd be better if you could say, yeah, I ate ice cream every night.
Yeah, or like, okay, so I'm not like doing high intensity workout, but like seriously, it shouldn't be that much. And it's significant in a certain area of my body. It's not in my legs, or I'm sorry, it's not in my ankles.
Yeah.
It's not my shins, not my feet. Sometimes in my arms. Somebody asked about compression stuff.
Yeah.
I haven't really tried compression on my upper legs other than like all the workout stuff I wear.
It might be worth it. Something to think about. Good suggestion.
For sure. But there seems to be a lot of people, like you said, that feel this way.
Yeah.
So,
and I think if you could find the magic bullet for this. So again, in some patients, I get the right mast cell treatment protocol, and yep, there goes the weight. But and they do better. Anything that's going to trigger the mast cells is going to promote this problem. So it could be that you're in a state of that. But I want to bring this up because I think it's important. So many of my patients where this is a problem really have an underlying issue that's driving the mast cell, and the underlying issue is infection. Across the board, if you ask me, the main thing that's making people sick, at least my patient population, is infection. And the reason it's infection is because the environmental toxins that they're being exposed to is breaking down the immune system, which is then breaking down the ability to fight the infection. And Bartonella, I hate to sound like a broken record, Bartonella, maybe Babesia in some cases, can cause swelling, can cause weight gain. I had a patient who gained 150 pounds, not in a year, but in a course of several years. And, very busy, a high functioning guy who, was running his own business. So, was entertaining people a lot, didn't really think about it, knew he was gaining weight. Certainly the diet wasn't good, and he acknowledged that, but his lifestyle didn't necessarily completely explain 150-pound weight gain. So, so what do? I start digging. What's causing this? So yes, there's a metabolic problem. He's insulin resistant. He's pre-diabetic. Okay, I expected I would see all that. What we found was that, and he had a history of a tick bite. We found Lyme disease, we found Bartonella, we found Babesia. And as soon as we started treating him without any radical change in diet, although I wanted him to make a radical change.
Sure, yeah.
He lost 60 pounds in like 3 months. Nobody loses 60 pounds in 3 months.
No.
You
Just
can
like
get-
nobody gains it in like 15 pounds in 6 days.
Exactly. And that's why when I've treated the thing that was driving the inflammation, okay, he did not have MCAS, but it doesn't matter, right? It just,
Right.
my point is that, you know, he came in like, why did I gain all this weight? And I go, okay, we found the Lyme, we treat the Lyme and the co-infections, and 60 pounds comes off. And then he says, you know, I'm cheating on my diet, I'm still losing weight. Well, again, how is that possible? It's possible because we've reduced the inflammation that's driving that. So I think that for a lot of people who are listening, I don't want to say that everyone has Lyme disease. I certainly don't want to say you have Lyme disease, but it's a possibility and it's something to think about.
Maybe it's the fact that I moved to the country around the same time.
Interesting.
I will also say that spins it to this too, is that one of the things I've also noticed is that my cardiovascular ability has been tremendously impacted. And when I was training for the Army 10 miler, I was so frustrated because I could not make headway on my cardiovascular capacity and strength like I'm used to. Plus, my joints were hurting in a way that, look, I have EDS. I have never had joint pain like this in the way that it hurt. And I was like, what is going on? So it wasn't just that, it was also my cardiovascular ability. I walk, I exercise every day, but it's affected it to the point that this is just odd for me. Also feeling joint pain in different areas. So the next from my own, where I'm going, is the toxin test.
Okay, do the toxin test and then check IGenics and test for Lyme, Babesia, and Bartonella, and then get back to me. We'll talk.
Yes, we'll talk about this another time, but it's very interesting we all talk about this because here's somebody, I have been diagnosed with MCAS, I have EDS, I have Hashimoto's, I have all these things, and they've all been just, so yeah, open record with my knee fat that I can grab on my legs.
Thank you for sharing though, because I think it does help a lot of people, you know, to understand that they're not alone.
No.
And you can't stop looking for answers. That's the point.
No,
right?
for sure. Even when you have, even when you have wonderful doctors that you work with and you've been diagnosed by the right people, I mean, it's still a journey.
Yeah. And I want to go back to diet again, because for some people, even the littlest indiscretion is going to be felt in a magnified way. So I know people, you all know people who go out, they pig out, they have a whole bottle of wine, whatever. 2 days later, you know, they're paying the price, but they certainly didn't gain 10 pounds from that, right? And then there are patients in my world that, you know, will have a slice of, I don't know what, like a little piece of cake, a few pretzels, whatever, a carb. And let's say they've been not eating carbs. They also will get water retention very, very quickly. They'll gain like 10 pounds literally overnight. And MCAS drives some of this. And so I still think it's very important that even if you don't think the diet is helping completely, that you get enough fat, you get the carbs out, because if not anything, it's going to help some things. And it's about chipping away at this, because there's never going to be one answer. There's never going to be one thing that's going to work. So I just want to bring that.
I think if you're comfortable wrapping it to a close, since we've talked about a lot of that, one thing somebody did ask is, can you talk about how Bartonella would affect your stomach? Because of course that's all linked. And if we were just talking about that, and it could also affect how gastroparesis and different things.
So I've seen Bartonella cause gastroparesis and then lead to SIBO, small intestinal bacterial overgrowth. It's not the Bartonella is not the bacteria in the small intestine, but it's sort of leading to that. So we often see that related. So a lot of patients feel bloated and uncomfortable, a lot of gas from that if they've developed SIBO. I've seen Bartonella cause, although we haven't been able to prove it, but I think that it's pretty high chance that it caused colitis. I've seen some links between inflammatory bowel disease and infection like Bartonella. And on biopsy, mast cells are there, and so they definitely have MCAS as well, but there's infection that may be driving some of it. So I've seen Bartonella cause quite a bit of GI symptoms, but also a lot of the other co-infections can too. I want to mention Babesia, because Babesia in children often manifests as nausea and decreased appetite. Seen that with Bartonella as well, but in kids, a lot of them will present more with the GI symptoms and less with the joint symptoms and the other symptoms that you attribute to Lyme disease.
Oh, very interesting. So I think somebody mentioned that the edema gets much better with weekly IV fluids like you were talking about. So I appreciate everybody's conversation. I appreciate dealing with our technical difficulties. It seems like we were able to pull it together. Thank you, Dr. Dempsey, for staying on longer.
Thank you. Thank you.
Of
course.
This is obviously, we love talking about this. We enjoy doing this. So thank you again for being for your patience, Dr. Dempsey, for your patience with the technical difficulties earlier, and everybody else's technical difficulties and your questions. The recording will be on Facebook Live, but I will actually make an edited one and share that as well. So thank you again, and we look forward to seeing everybody next time.
Thank you, Kendra.
Thank you. All right.